Hey, have you wondered if you have a hair loss disorder? Or if you've been struggling with hair thinning, then have you wondered what type of hair loss you have? There are different types. And my guest today, Rob English, will help answer many questions such as the different types of hair loss, do natural ways of addressing hair thinning work, and how companies cheat clinical trials to show fake hair growth results. Rob English is a researcher specializing in hair loss disorders. He sits on the editorial board of Dermatology and Therapy, and he's the founder of PerfectHairHealth.com, a website that showcases evidence-based protocols for hair regrowth with and without drugs. His fascination with hair loss began in 2007, right after he was diagnosed with androgenic alopecia. Today, he spends his time teaching others how to avoid all the mistakes he made while seeking treatment. By employing an approach that prioritizes education over product purchases and one-on-one support over one-size-fits-all solutions, he's helped thousands of men and women improve their hair loss on their terms. You can see his clients' testimonials, read his peer-reviewed papers, and contact him directly at perfecthairhealth.com. Before we start the interview, if you've been listening to the channel and you like what you're hearing, make sure to hit the subscribe button down below so you can get notified when we release new episodes. Our goal with this channel is to help you look and feel younger so you can live your most confident and adventurous life. All right, let's get right into it. Hey, my friend, welcome back to the Anti-Aging Hacks podcast. Today, my guest is Rob English, who's a researcher specializing in hair loss disorders. He sits on the editorial board of Dermatology and Therapy, and he's the founder of Perfect Hair Health, a website that showcases evidence-based protocols for hair regrowth with and without drugs. His fascination with hair loss began in 2007, right after he was diagnosed with androgenic alopecia. Today, he spends his time teaching others how to avoid all the mistakes he made while seeking treatment. By employing an approach that prioritizes education over product purchases and one-on-one support over one-size-fits-all solutions, he's helped thousands of men and women improve their hair loss and on their terms. With that said, Rob, welcome to the Anti-Aging Hacks podcast.
Thanks for having me. I appreciate it.
So I've known about you and known you for a couple of years, and we've exchanged some emails back and forth and had a conversation or so. But what I love about you is your propensity towards research and getting to the root cause of a lot of these problems. We know that hair loss is multifactorial and it's complicated, but I think having you on the show and getting your perspective on what's causing some of these disorders would be really good for the audience. So as in terms of your background, please explain, how you got into hair loss of all things and what you've been up to since you got into it.
Sure. Well, that was a very flattering introduction. Thank you. Just to give you an idea of what I'm doing today, my name is Rob English. I'm a medical editor specializing in hair loss disorders. I have published 5 peer-reviewed publications on a hair loss disorder called androgenic alopecia, or male and female pattern hair loss. It's one of the most common types of hair loss in adults. One of the papers is on a hypothetical pathogenesis model. Another is on an experimental intervention. 2 are on literature reviews. And a final one is about why there might be conflicting reports for biopsy-related research in androgenic alopecia across investigation groups. I also run the website perfecthairhealth.com, which, as you said, showcases evidence-based protocols for any type of hair loss type, with the drug model, without the drug model. What matters to me less is the path that somebody chooses, and more so that they're not avoiding certain treatments due to their exposure to misinformation or disinformation, and that they're navigating through treatments effectively and efficiently and getting the best of the best types of suggestions. And I'm also on the editorial board of Dermatology and Therapy. So that gives me some insights into what's coming down the research pipeline, the peer review process, what researchers and investigation groups are currently talking about. So this is just a long-winded way of me saying that hair loss is my career and research is my career. But I guess what makes me unique in the sense of people who do this type of academic work in the hair loss space is that I'm actually not a technically trained academic. I actually fell into hair loss research out of self-interest because back when I was 15 years old, I started noticing, my hair is starting to thin a little bit. Other people started to point it out to me as well. At 17, I went to a hair loss specialist, a doctor who's a hair transplant surgeon, and he diagnosed me with androgenic alopecia, also known as male pattern hair loss. And then over the next 6 years, in my attempts to find treatments that fit with my preferences, I just ran into so much misinformation and fear-mongering over drugs and exposure to bad information that influenced my treatment protocols and preferences. that I really was spinning my gears, spending a lot of money on the latest and greatest topical supplement device that looked super promising on paper, that was really well marketed to me, but that I would try, feel disappointed with the results, and then later I would learn that the evidence supporting these interventions wasn't as high quality as I wanted. So eventually this experience led into the culmination of perfecthairhealth.com, and eventually my progressive involvement in different hair loss disorders, to the point where eventually I started to publish papers and then began to manage a small research team, and then find my way onto an editorial board of a dermatology journal. And this is where I am today. So the journey into hair loss research was entirely inspired out of self-interest.
Wow, that's great to hear. And I had my first bout of hair loss when I was 19 as well. And I can personally attest how harsh it is for a young man to be going through hair thinning, or to shampooing his hair and finding hair in his hands, and thinning and finding thin, weak hair as well, which obviously provide evidence that there's androgenic alopecia involved. And so, and Rob touched on, the website and the blog that he has, where he talks about a lot of these myths, misconceptions, and things that may work in the hair loss world. And I've certainly spent my fair share of time reading some of his very well thought out and reasoned arguments. So if you have a chance, you should check out his blog. It's really cool. So Rob, with that said, I have a ton of questions for you. Let's get right into it. You have a unique perspective because you're a researcher and you've been doing this for many years. So you look at scientific studies and you can boil that down for the common person. And so everything on this show is all about science. And so I welcome your perspective on this. So with that said, let's get started with, what's your perspective, Rob, on what factors cause hair loss?
Well, it's incredibly context specific. So the factors that cause hair loss depend on the type of hair loss you're facing. And obviously the type influences the causes, which influence the treatments. I think that before we even get into that, one of the challenges at the outset as a consumer is that bit of knowledge, types, causes, treatments, aren't even discerned. And part of the reason why there's so much confusion online for individuals trying to figure out what's causing their hair loss and how to fix it is because this condition is so multifactorial, because multiple hair loss types often overlap with one another. But then the bigger picture is the fact that profit incentives in many ways disadvantage consumers looking for answers at multiple levels and for different reasons. So you have different profit incentives at a doctor's office, at a dermatologist's office, and then at an online level. So say if you decided not to type into Google what causes hair loss and you just went straight to your doctor. Your doctor, if you're an adult, is most likely to diagnose you with the world's or one of the world's most common hair loss disorders, androgenic alopecia, also known as male and female pattern hair loss. And that's because this condition is almost ubiquitous. It tends to increase at a prevalence of 10% per decade. So if you live long enough, there are studies out of Singapore demonstrating that 80-year-olds have an incidence of 100% androgenic alopecia. Wow. So it's not unreasonable for them to diagnose you with this type of hair loss. For men, it often begins as temporal recession and a bald spot, and then progresses to a slick bald scalp. And for women, it presents more diffusely. The problem is that doctors, they are incredibly busy, and to keep their doors open, they have to see multiple patients every single day, which shortens the availability of their time with each individual patient. So if you look at the data, a family physician manages something like 2,300 patients. They work on average 59 and a half hours per week. And for new physicians, patient-physician interaction time is less than 8 minutes. So you look at those data points and you think, okay, here's the world's most common hair loss disorder. I don't know a lot about this individual. I'm going to diagnose them with what makes the most sense based off of their characteristics of their hair loss and what I know what might be prevalent at this time for this age group. What gets missed during that interaction is a full health evaluation in most cases. Thyroid-related work, micronutrient deficiency-related work, questions about overall health, acute stress, chronic stressors that might also be contributing to hair loss. And so oftentimes these individuals are prescribed FDA-approved drugs, things like finasteride, or told to start taking minoxidil. And for a majority of cases, that can work really well. However, it's complicated. Sometimes you miss that other component with the doctor's appointment. So say if you didn't do that and you went to a dermatologist, A dermatologist has a longer time with you, about 20 minutes. They're going to be able to do a scalp analysis. They're specialists in skin disorders. They're going to look through a dermoscope, a dermoscope or some sort of microzoom device to analyze the follicles themselves. They're going to get a little bit more granular, and the best ones are going to give you a health evaluation to discern if you're dealing with multiple hair loss types. The problem, though, is that dermatologists have a different profit incentive than doctors. Dermatologists keep their doors open by selling patients into high-ticket, profitable therapeutics. So if you've ever done platelet-rich plasma for anything, that was repurposed for hair loss disorders like 15 years ago. And then 10 years ago, it was PRP plus A cell. And then it was PRP plus stem cells and adipose-derived stem cells. And the latest thing has been exosomes. And these things cost anywhere from $1,000 to $10,000 a session. And there is clinical data to support their use as a treatment modality. The thing is that data suggests that these interventions kind of net you between 10 to 30% increases to hair counts. And what that dermatologist isn't going to tell you is that there are at-home devices like microneedling rollers that cost between $10 to $30 that can elicit the same exact increases to hair counts according to clinical data. They tend to net you through the same mechanisms, acute inflammation generation. And in split scalp studies, when you microneedle one half of the scalp and you do PRP in the other, the microneedling performs just as well, if not better, than the PRP side. So you look at these data points and you think, well, that's another consumer disadvantage point for profit incentives from dermatologists. They withhold that type of information because they want to keep their doors open for other reasons. They want to make sure to sell you into things that do have clinical support, but maybe won't advantage you from the consumer perspective. And then at an online level, it's just a minefield. So you have companies that incentivize research or position research in such a way to sell either a product line that is either natural or conventional. You have tribalism on hair loss forums, whereby people believe that FDA-approved drugs are the only way to see regrowth. And so you'll get people that downplay the evidence on natural interventions and vice versa, depending on which forum you're reading. So it's really hard as a consumer to just get your access to good information. And it's these profit incentives that kind of shape the landscape. But to go back to your original question, what are the factors that influence hair loss?
Actually, can I pause you for 1 second? I love what you just said, because if you're listening and you have a hair loss problem or disorder that you're going through, I'm going to make a blanket statement. Don't go to your family physician. They don't know enough. They don't have the time. They're trying to treat a whole range of conditions. Go to a specialist of some kind. Rob mentioned dermatologist, way better, but the dermatologist is going to try to sell you a PRP or an exosome treatment, which again, it's just they're financially incentivized to do this. And I've been to many of these dermatologists, and sometimes I've heard them say that we're going to try 3 treatments of PRP 4 weeks apart, so 1 a month, and then we'll do 1 every 3 months. And at the end of 3 to 4 months, we will see how they do. The only problem is you're out $3,000 to $6,000 by that point, and for them to see how you do after $6,000 or $3,000 seems a little bit too much for me to bear, right? And so that's what Rob is saying. The other thing, Rob, that I've heard from a lot of women is that they place their trust on hairstylists who are even less educated than the medical professionals. And so any company that's marketing to a hairstylist or hair salon can get their product in there. And now, lo and behold, you have the stylist selling for you, and the incentives are not clear how much percentage of that the stylist is getting. So there's a lot of complications that happen with where you're getting this information from. And so please proceed with the causes or factors of hair loss now.
That's a really good point. Just to piggyback off of what you just said, based off of almost all the women with whom I've had the chance to work with, a lot of them, when they come to me and we have a consultation, will talk about how they found out that they're losing their hair and they either went online or to their salon stylist and have been taking biotin supplements for the last 6 to 12 months.
Yes.
That is a huge one. So I personally also used to take biotin supplements for hair loss because I ran into the same information. I was given the same pitches. Even healthline.com, Medical News Today, these really well-funded, prestigious, credible resources of information for health advice will sell and affiliate with biotin supplements for hair loss in their articles about the top 14 foods for hair growth or the 10 supplements you must be taking now. And what you don't know is that if you just clicked into that little resource that they cited as a means to say that a biotin deficiency causes hair loss and that you could regrow hair by taking biotin supplements, if you clicked into that, you'd realize that the principal paper that everybody cites for the use of biotin for hair loss is this case report literature review series on 17 or 18 people who did have a biotin deficiency, but they had a biotin deficiency. They took biotin supplements, they saw hair regrowth. All of those participants were 5 years old or younger, and they had a rare genetic mutation called a biotinidase deficiency, which occurs in 1 out of every 110,000 individuals. So the degree by which you have to have a specific genetic mutation to elicit a biotin deficiency to the point where it actually causes hair loss, and thereby you benefit from supplementing. Of course, there is a context-specific moment where that makes sense and that you should make that recommendation. But barring testing for biotin deficiencies and barring those specific circumstances, or others like having ulcerative colitis or alcoholism or antibiotic abuse, all of which can depress biotin synthesis, it really doesn't make sense to be recommending this as a frontline treatment for individuals. So it's just a really good point that you brought up, and I wanted to also kind of piggyback off of that and explain that it's tough out there. But building off of everything that we just talked about, the factors that involve any individual's case of hair loss root back to the types of hair loss they're facing. So if we just did away with most, obscure or less prevalent causes of hair loss, things like alopecia areata and scarring disorders, which certainly impact a significant number of men and particularly women, but aren't necessarily at the forefront of diagnoses. And we just boiled things down to the 2 types of hair loss that are most common in the developed world. You're looking at androgenic alopecia, and then you're also looking at telogen effluvium. So let's start with that first category, androgenic alopecia. Androgenic alopecia, like we said earlier, it's almost ubiquitous if you live long enough. It's defined by hair follicle miniaturization. So when a dermatologist is looking for hair follicle miniaturization, they'll look to see if the strands of hair in any single area represent hair diameter diversity, meaning that you'll see some strands that are thinner and some strands that are thicker than others. And if that's present, that typically means that miniaturization of the follicles are happening and that you likely have androgenic alopecia, which is this chronic progressive hair loss disorder that without treatment generally just worsens. Now, the causes of androgenic alopecia are generally believed to be, according to the best data that we have so far, predominantly androgens, male hormones like dihydrotestosterone, and then genetic predisposition. There's also an argument that environmental factors are at play, because we know that when we take genetically identical twins and we survey them based off of specific life experiences and habits, some of those twins can bald at an accelerated rate, meaning that environment, diet, nutrition, lifestyle also has a factor in this. We'll get into that when we talk about telogen effluvium. But the big point here is that the data very strongly implicates male hormones, specifically testosterone and dihydrotestosterone, or DHT, in the onset and progression of androgenic alopecia. And this data dates all the way back to the 1940s, starting with this guy, Dr. Hamilton, who observed in male castrates that men who were castrated before puberty and thereby experienced a 95% drop in testosterone and thereby a metabolite of testosterone known as dihydrotestosterone, or DHT, those men, when they grew up and aged, were relatively protected from pattern hair loss. So that was kind of one of the first big signals to say, oh, interesting, male hormones are probably involved in the onset of this condition. Maybe we should look further into that. You fast forward 30 years, research on the islands of Guam and Papua New Guinea demonstrate that these anecdotes are coming out about these individuals who have what's known as a genetic deficiency in the type 2,5-alpha reductase enzyme. That's an enzyme that converts testosterone into a metabolite of testosterone known as type 2,5-alpha DHT, or dihydrotestosterone. And interestingly enough, these men perfectly preserved testosterone levels later in life, and yet also were protected from male pattern hair loss. And so now you're looking at these anecdotes and you're thinking, okay, well, we know that testosterone might not be the thing that's the big factor. Maybe it's the subset dihydrotestosterone or DHT. And then it was just about 10 years later that men using a drug for benign prostate hyperplasia or BPH, finasteride, started to report in these clinical trials through the FDA that they were also regrowing hair. Well, finasteride happens to be a type 2 5-alpha reductase inhibitor. So it lowers that specific hormone, type 2 5-alpha DHT. And in doing so, it lowers it at a therapeutic threshold where hair count improvements begin to happen at the top of the scalp. And you begin to see the reversal of hair follicle miniaturization. Then those trials got expanded and things looked really good for that drug. So over a 2 to 5 year period, typically finasteride can stop the progression of pattern hair loss in 80 to 90% of men, lead to a 10 to 15% increase in hair count over 2 to 5 years. So then you got more and more data coming out demonstrating that in Petri dishes, you bathe miniaturizing hair follicles in DHT, they continue to miniaturize. You take away the DHT, it doesn't happen. So that's really the big driver of the first category of hair loss, male pattern hair loss. And we know that at a mechanistic level, at an observational level, and then at an interventional level, that hormone DHT is causally linked to the progression of this condition. And that targeting it, whether through conventional or natural means, is probably a good idea for people experiencing this type of hair loss. So that's the first big bucket.
Okay, one quick point to that, Rob. I come across a lot of people, especially in their 30s and 40s, that start supplementing with exogenous testosterone. So this, as Rob mentioned, a metabolite of testosterone, DHT, causes hair thinning in men and women. And so if you're exogenously adding more testosterone to your body, a portion of that will, of course, convert to DHT, which will exacerbate or start your hair thinning if you haven't had any yet. So just be careful if you're using testosterone supplements or therapy, then that's something you got to consider as well. Please continue, Rob.
The second category of hair loss that is something that should be on everybody's radar is telogen effluvium. Now, telogen effluvium actually doesn't involve miniaturization. So the hair strands don't get thinner and thinner over time like we see in androgenic alopecia. Instead, telogen effluvium is what's known as a hair cycling disorder or a hair shedding disorder. So one presentation of telogen effluvium is when too many hairs shed out ahead of schedule, and then there's a gap between when those old follicles have degenerated and the new follicles have regenerated to take their place. So you get a loss of density overall. This tends to present more diffusely across somebody's scalp. And so what's interesting is that if you actually just look at our hair cycle, hair follicles are kind of like these mini organs that have the capacity to regenerate over and over and over again. So studies very clearly show that for 2 to 7 years, any hair follicle is in its growth stage where the hair is growing out. And then for a few weeks, it enters what's known as a resting stage where the actual strand of hair detaches from its follicular base and then forms a club at the end. And then over the next 2 to 6 weeks, that hair that's been disconnected from its blood supply for however long works its way out of the hair shaft, falls out, the old hair follicle collapses, and a new one comes in to take its place. So at any given point, between 10 to 15% of our hairs are in this state of shedding, which is why it's totally normal to shed 100, sometimes 150 hairs daily, depending on our starting hair density, even in the absence of a hair loss problem. So what telogen effluvium is when that 10 to 15% threshold pathologically increases to 20% or greater. And there are 1,000 factors that can influence this. And misinformation around the conflation of cause and effect for androgenic alopecia and telogen effluvium, I feel is one of the biggest pain points for consumers. Because when you read these articles online, what causes hair loss, the information that these articles give in many cases is accurate, but it's not contextualized into which type of hair loss we're talking about. So people conflate cause and effect across hair loss disorders and then delay proper treatment. So let's go through a few of the causes of telogen effluvium. The first few are acute stressors. So we have studies demonstrating that anything from moderate degrees of work stress, even working greater than 50 to 60 hours per week for an extended period of time, can accelerate our rates of hair shedding. all the way to bereavement or the loss of a loved one, or childbirth, or trauma due to surgery. All of these things can trigger what's known as acute telogen effluvium, where that shedding rate can go above 20%. Now, the nice thing about telogen effluvium is that it's oftentimes temporary. If you can identify the underlying trigger, address the causes, within 3 to 8 months, that hair cycle normalizes, and then the hair starts to grow back. And within a year or so, it's as if you never had a problem with hair loss to begin with. So acute telogen effluvium, really all you need to do is just give yourself time to recover from those events. Chronic telogen effluvium, the causes are a little bit more nebulous and a little bit harder to track down, and oftentimes involve the need to do a little bit of lab testing. So we're looking at things ranging from micronutrient deficiencies in vitamin D, iron, B12 is potentially associated with some forms of telogen effluvium. We also have biotin deficiencies at the extremes, of course. And then you also have other things related to chronic conditions. So hypothyroidism, anecdotally, there's been a lot of reports of hyperparathyroidism being linked to telogen effluvium. You have a wide range of possibilities. And then there's also certain medication usages, non-steroidal anti-inflammatory drugs, certain medications that are used regularly also tend to exacerbate bouts of telogen effluvium in individuals. A lot of men who undergo telogen effluvium, it begins as use for Accutane or high-dose isotretinoin, these retinoic acid derivatives or synthetic versions of retinoic acid. So men treating acne will go through this huge shed of hair, wonder what's happening, and it turns out that in many of those cases, the shed was caused by the Accutane drug. So it's just important to think about these things in terms of those two contexts. The one thing that I want to emphasize in what causes hair loss is that these two hair loss disorders, they don't exist in a vacuum. They're not mutually exclusive. You can have both simultaneously. And on that note, there's a very important interaction point that needs to be discussed. And that's that with androgenic alopecia, you have this defining characteristic, hair follicle miniaturization. And with telogen effluvium, you have this defining characteristic, excessive hair shedding. But the only way that hair follicle miniaturization can happen in androgenic alopecia is actually through hair shedding. So if you measure a hair that's affected by AGA at its tip, all the way down to its root, it's the exact same diameter. The way that the miniaturization step process happens is that the hair falls out due to natural shedding, the old follicle collapses, a new one comes in its place, but as that new follicle is forming and this cell cluster known as the dermal papillae cell cluster begins to grow, the action of that hormone DHT begins to attack the base of the follicle, induce a signaling protein that damages the follicle, causes apoptosis, and the follicle size goes from here, which is where it was in the last cycle, to here. In that regard, now you're stuck into a slightly thinner hair strand that's going to grow out and then shed out. And so the problem with this type of hair loss is that you can actually have telogen effluvium unmask androgenic alopecia. So you can go through these really stressful periods at work, or go through bereavement, or a surgery, or a micronutrient deficiency that goes unaddressed. And you can develop telogen effluvium. And then you can correct for that telogen effluvium-based shed. But now when that hair begins to grow back in, it grows back in a little bit more miniaturized than the last cycle. And the concern for consumers there is that you can end up in this position where you're confusing cause and effect. So you can end up whereby you think that your hair loss is now because of this telogen effluvium-based shed. And if you resolve the stress, now you're going to be fine. Well, that's not necessarily the case. Now you also have to target androgenic alopecia. You have to find a way to therapeutically lower DHT or get on interventions outside of DHT reduction that have an effect on this condition. And so it really requires a full encompassed approach to treat these cases whereby telogen effluvium sheds feed into androgenic alopecia.
Mm-hmm. That's fantastic. So Rob just mentioned two different types, but there's two subtypes within one. Androgenic alopecia, which I'm going to ask you a bit more questions, where the follicle actually thins, so you can identify that this is a specific type of hair loss when you can examine your hair follicles. Maybe there's two different hair follicles or hair that's fallen out, and you can see one's way thinner than the other. Maybe that gives you an indication that you are undergoing androgenic androgenic alopecia. The other point is telogen effluvium, of which there are two types. One is acute, which again, as Rob mentioned, acute injury, childbirth, some trauma. But if you wait long enough, that will resolve by itself. So it's not a long-term worry. The other one, which is chronic telogen effluvium, which means it just goes on for a long time, that's a worry, and you need to get into that and figure out what's going on. And oftentimes, both of these can happen together, or the shedding from chronic telogen effluvium can mask what's happening is that there's androgenic alopecia going on as well, which makes it harder for you to figure out what to do first or what to do together, if so to speak. So Rob, let's just go do this exercise. And I kind of alluded to it, but how can somebody tell what type of hair loss they have just by examining their hair follicles from a self-analysis perspective?
It's a great question. So a lot of times people don't have a doctor or a general physician who is educated enough in these intricacies to give them a proper diagnosis or a full health evaluation. And then at the dermatologist, you have the problems we talked about. And then online, you're dealing with a complete disaster of information. So what can you do at an individual level? Well, while a hair loss specialist is going to be your best resource, not everybody has access to them, or not everybody has access to good ones. There's a ton that we can do from an at-home perspective to help identify what types of hair loss we might be facing. So the next time that you're in the shower and you start to notice some hair that's shedding, stick it against the wall, preferably a white backdrop, so that you can actually look at the entire hair. And what you'll be looking for is hairs that look thinner versus thicker than others. And if you notice that, that term is known as hair diameter diversity. It means that some follicles in your scalp are likely miniaturizing. And that's a really good diagnostic criteria that the best of the best dermatologists will use to discern if you might have androgenic alopecia. So that can give you some early insights right there. In terms of telogen effluvium, you can also test this at home. So what you can end up doing is what's known as a wash test. So for 5 days, you don't do any hair washing whatsoever. And the idea is that you hopefully want to collect a lot of the hairs that would have shed against other hairs, because the oils that are produced by our skin will help to hold those together. Then you're going to plug your drain, wash your hair, let the hair dry, and count the number of hairs and the length of those hairs. If you have a shedding rate over 100 to 150 hairs daily for that 5-day period, then that suggests that you might be dealing with telogen effluvium. If 10% or greater of those hairs are 3 centimeters or shorter, that suggests that there's a chronic telogen effluvium going on, or the early stages of androgenic alopecia, in which case it's time to do a little bit more diagnostic work. Do you have a familial history of hair loss? Have you been through any stressful events recently? Have you done nutrient panel testing? Do you have any symptoms related to the conditions that can underlie chronic telogen effluvium? We're talking about gut dysbiosis, hypothyroidism being one of the biggest two. You have to start to ask yourself those health questions. And if you just do that exercise, it's likely that you can save yourself tons of time, tons of money, tons of hair, and get a better idea for your overall health picture and hair loss outcomes, so that you can start to seek treatments that actually make sense for you. And that helps to circumvent some of these problems that can be present at the doctors, the dermatologists, and elsewhere. Obviously, people are doing the best they can with the resources that they have. So I don't want to necessarily rally against doctors in any way. I think that doctors save lives on a regular basis, and that I'm forever grateful for them. I had my appendix removed in 2005, and if it weren't for doctors, I'd probably be dead right now. So I love doctors, but also they face significant time constraints in a healthcare system that is not necessarily beholden to helping individuals. And they're up against those constraints. They're not going to be able to check you out in the ways that you can. Fortunately, we know that there are these at-home tests that can help you really, really get closer to answers.
Fantastic, Rob. I have a follow-on question about telogen effluvium, the chronic kind. Rob mentioned there's a lot of conditions, including nutrient deficiencies, that could be the cause behind this type of hair loss. If we were to count some of those, I think you mentioned iron deficiency, vitamin D, B12, thyroid, hypothyroid or hyperparathyroid. Are there gut dysbiosis? Are there a few tests that people can maybe go to their doctor or go to a lab to get? And if you could save people time and money, how would you categorize those tests to say, get this, this, and this, and that should give you a relatively good idea of telogen effluvium? Or is it too complicated to even go there?
It's a little complicated because it's individualistic in nature. So I wouldn't necessarily recommend to a postmenopausal woman an iron test, but I might recommend that to a female who's plant-based and has been losing her hair with excessive hair shedding and who is under 40 years old. So a lot of these nutrient-related tests are context-specific. At the same time, you're absolutely right that there are some that just should be done regardless of hair health, but for overall health. Vitamin D status, depending on the marker for optimum vitamin D that you believe in, upwards of 40 to 50% of Americans are vitamin D deficient. So, of course, because of vitamin D's role in potential telogen effluvium related sheds and the interaction points with androgenic alopecia, it makes a ton of sense to go and get that test. If you are also dealing with chronic fatigue, cold hands, cold feet, brain fog, those are symptoms of thyroid disorders, and it makes sense to also do a TSH test. And if that shows up a little bit off out of whack, then maybe doing additional thyroid testing with T3, T4, reverse T3, whatever you need to do under the guidance of a medical professional to understand if this is Hashimoto's thyroiditis, if this is just typical hypothyroidism, maybe related to crash dieting, if this is autoimmune forms of thyroid disease. These things need to be discerned at a more granular level. But the big ones are to just do those health evaluations and ask yourself these questions. Then based on the answers that you're giving yourself, you'll have better insights as to what to do next. For example, if I am facing, if I'm not healing well, if my wounds tend to take a long time to heal, that's indicative of a vitamin D deficiency. I would want to prioritize that test. If I'm having peripheral neuropathy, that suggests that maybe my B12 levels are low. I would want to prioritize that test, especially in the context of excessive hair shedding. But if I'm like a super healthy person and I am just losing my hair and it looks exactly like male pattern hair loss and I have no scalp-related inflammation, it's just typical male pattern hair loss, in that case, I wouldn't necessarily prioritize lab testing at all. I think that it would be important for that individual to save themselves that money and put that toward treatments that are effective and that fit with their preferences.
Okay, that makes sense. Here's another question for you, Rob. And this is a 20-second answer, please. Could you say that if either of your parents have hair thinning or significant hair loss, then there's a high chance of you inheriting androgenic alopecia from them, and therefore that's certainly something you got to investigate?
100%, yes.
Okay, so it comes from both sides. It's not just the mom or the dad, like a lot of people talk about.
There are 220 plus genes associated with androgenic alopecia, both on the male and female side. So the idea that it might skip some certain generations or only come from the maternal side or paternal side of the family hasn't been proven out yet. There are plenty of cases where those genes tend to be present and the parents don't express any pattern hair loss, but the son does. So it's so ubiquitous at that point in the general population that if you live long enough, you likely will experience some degree of it. But again, that rate and that degree and prevalence is determined by the rate of hair shedding and how much miniaturization takes place in between those hair cycles.
Okay, here's another question. Are these types of hair loss reversible?
So there is a difference between possible and plausible. The best clinical data that we have on DHT reducing drugs like finasteride and dutasteride suggests that over a 2-year period, you can basically get back for 80 to 90% of individuals taking these drugs, an average of 30% hair density. That's a significant amount, especially if you seek treatment early on. But then you hit this plateau. Part of that reason is because alongside hair follicle miniaturization, you end up developing what's known as parafollicular fibrosis or scar tissue toward the mid to late stages of miniaturization. And that scarring acts as a roadblock for resizing of the hair follicles. So you can knock out DHT as low as you want, but the scarring will still remain. That'll prevent resizing, and you can't grow hair where scar is. Now, I say this knowing full well that there is a case study from the 1980s on a 78-year-old bald man who had basically been bald for 30 plus years, slipped in his rocking chair, fell backwards, burned his scalp on hot coals, went to the emergency room, was a curmudgeon, didn't want to be treated, so they had to send him back as an outpatient, came back 3 months later, said that his bald patch was filling in, came back 6 months later and had his juvenile hairline back.
Wow.
So there is a difference between what expectations should be set at a consumer level, but then what we've actually seen in the clinical data. In fact, scarring alopecias, where the scarring is entirely insidious, whereby you entirely wipe out the existence of a hair follicle stem cell bulge and evidence that hairs were even in that tissue to begin with. Women have accidentally reversed these insidious forms of hair loss by just removing the use of forehead sunscreen. So there's a lot that we don't know about cross-cellular signaling from hair follicle organs that haven't been impacted by these disease states. There's just a lot that we don't know yet. And that's kind of the frontier of research right now, is that how can we get healthy hair follicles to start talking to miniaturizing ones? It seems to have happened accidentally several times in the literature across a variety of hair loss disorders that were previously believed to be irreversible. So now it's about how to get those therapeutics into the general population with safe modalities. We don't have those answers yet, but it is 100% possible to fully reverse male pattern hair loss. I absolutely believe that. It's just not plausible for every individual, at least not yet.
Wow. This is amazing news, Rob. I didn't even know this, and I've been researching hair loss for quite a few years. So thank you for sharing. And the other type of hair loss, so Rob mentioned androgenic alopecia, which again, miniaturizes your hair follicle. Rob believes this can be completely reversible given the right type of individual. Now, there's the other type of hair loss that Rob also touched on, which is scarring alopecias, and there's a lot of these different kinds, and a dermatologist has to actually classify these. These can also be reversed in some ways. Again, some anecdotes of people doing this. But the other type of hair loss we talked about was chronic and acute telogen effluvium. We know that we don't really have to worry about acute telogen effluvium because that hair comes back. But for chronic, Rob, is the chronic case, regardless of nutritional deficiencies or hypothyroid or hyperparathyroid or vitamin D3, is all of that reversible given that you have the right intervention?
I think that part of the presumed irreversibility of chronic telogen effluvium in the research comes from the fact that we're not always able to discern the causes. So I can give you an example of somebody that I recently worked with chronic telogen effluvium. She had been suffering from excessive hair shedding for 10 years. She had been passed around a dozen dermatologists, all of whom couldn't give her a clear diagnosis. She had tried all the conventional treatments for androgenic alopecia, nothing changed. She tried overhauling her diet, nothing changed. She did thyroid supplements, thyroid medications, nothing changed. We did a full health evaluation, and it turned out that she had some amalgam work done in a period where mercury amalgam installation was very popular. She went and got those tested, and she got her blood levels tested, and it turned out that she had a 10 to 15-fold higher level of the highest range of mercury in her blood as possible. Got her mercury amalgams removed, and bear in mind, this is 10 years of shedding for this individual. And for the first time is now seeing significant hair growth that is actually able to elongate beyond that 3-centimeter mark. So in my eyes, the irreversibility or the perception of irreversibility for chronic telogen effluvium just comes from the fact that it's really hard to pin down the types of causes that might be going on for any individual. But I also believe that those are reversible.
Mm-hmm. So folks that are listening to this show, subscribe to the view of the anti-aging view, right? That we can reverse and look good even in our later years. And in the longevity revolution, which is taking off right now, folks, just know that there is a potential out there that you can have a full head of hair even in your later years as you start to reverse your aging process as well. So this is great. Now, let's get into a different topic. And then at the end, I'm going to come back to some rapid fire questions for Rob. And this topic, we're going to talk about some of the ways that nutritional companies or hair loss companies cheat clinical trials or distort the data that comes back from clinical trials. So Rob, what can you tell us about this?
Well, as a study author and as somebody who's worked on clinical study design, I can tell you that you can set yourself up for success at the outset, and that a lot of clinical research that I read from nutritional hair loss companies tends to do this very thing. So there are some larger named companies out there that will design their clinical trials for a nutraceutical or a nutritional supplement for hair loss. And they'll set it up in a very peculiar way. So in their exclusion criteria for patients, they'll say that they won't accept anybody with female pattern hair loss, telogen effluvium, scarring alopecias, or autoimmune forms of hair loss. So right away, you've just eliminated almost all types of hair loss that you can believe. And then they'll include in their trials patients with self-perceived hair thinning, possibly from stress, micronutrient deficiencies, or menstruation. Now, if you actually understand the definition of telogen effluvium, you'll know that they're excluding people with telogen effluvium who have the severest forms of telogen effluvium, those acute types that are caused by bereavement, incredible degrees of stress, trauma, surgery, childbirth. And they're narrowing the definition of telogen effluvium to just meet that 50% threshold or greater for hair shedding. But then they're taking all of these individuals with self-perceived hair thinning that actually probably do have telogen effluvium, albeit from more of those minor causes. And they're selecting those individuals into their study. And then they're giving them micronutrient supplements, which we know will likely replete those nutrient values. And in doing so, help to normalize the hair cycle. And then after 6 months, these double-blinded, placebo-controlled, randomized clinical trials demonstrate a 10 to 15% increase in hair count. Well, no surprise there. You gave your placebo group a sugar pill. They maintained the same stress levels and nutrient deficiencies and menstruation problems. And yet you corrected for a lot of those in your other treatment group. So now you get to advertise that supplement to all hair loss sufferers, including those with all of the hair loss disorders that you actually excluded in your clinical trial. I find this to be incredibly infuriating, mainly because I would read these things and I would buy these supplements on the basis that these clinical trials applied to me, having no idea that they didn't. And so that's one really simple but deceptive way that nutritional companies can cheat these clinical trials. It's also not the only way that it happens. So what is another cause of telogen effluvium? Another cause of telogen effluvium is seasonal-based hair shedding. So if we live in the Northern Hemisphere, every July and August, we go through what's known as a delayed telogen release. This is when changes to UVB radiation from the sun and the reduction of daylight hours lead us to shed out a lot of hair that we hung on to in the summer months. It's completely normal. It leads to an increased hair shedding rate of about 10%. And for most people, it's cosmetically imperceptible, meaning that it's noticeable to you, but not to anybody who's looking at your hair on a regular basis. But it takes us right above that 20% threshold mark. So technically, we all have telogen effluvium once a year in the Northern Hemisphere, more or less. Now, low-level laser therapy and infrared light therapies, a lot of these devices have demonstrated some clinical benefit in hair loss trials, but through unknown mechanisms. Well, lo and behold, those devices tend to emit overlapping wavelengths with the sun. And as you enter into winter months, there is an argument to be made that these devices just help you delay that delayed telogen release by exposing you to the same wavelengths of light that you already were exposed to that prevented that shedding in the first place. So then you think, okay, well, if this is true, we'd have to kind of look and see when a lot of these low-level laser therapy device clinical trials are beginning. Because if they wanted to take advantage of this seasonal-based shed, they would start their trials in May and June, and they would end them around October. That would be their 6-month window. Well, you go into the database, and tons and tons and tons of these trials follow that exact protocol. And then they get to claim that their double-blinded, placebo-controlled, sham-controlled, randomized trial demonstrated that their low-level laser therapy device improved hair counts by 5 to 15%. And it's just a dishonest way to, again, cheat somebody into buying something for $3,000 that I can tell you in my 7 years doing this, I've yet to meet somebody who's told me that a low-level laser therapy device actually moved the needle for their hair. It's just a lot of, I think it might be working. At a price point that high, I think that it's worth educating consumers over how these devices might be leading to false conclusions.
I agree. And that is my beef with some of this stuff. So by the way, Rob, thank you for shedding light on what's actually going on. I've read a couple of the studies you talk about, and I was aghast as well at what's actually behind the scenes. And again, being in this space, I talk to a lot of researchers in longevity and anti-aging and health, and we look at studies, but you always have to get a level deeper into who's funding the study, what kind of data was excluded, in which case, in the first case you pointed out, that was extremely important because only a small minority of cases were being addressed by the supplement and the vast majority were being excluded, which to me doesn't make any sense. And then thirdly, I think the point you mentioned that if you're going to try an intervention with hair thinning, hair loss, in my humble opinion, try something that's on the cheaper side, like a $50, $100 range, see it for 3 or 4 months. As Rob said, it takes a little bit of time. Don't spend $3,000 on your first go just because a marketer is telling you, here's the data. You never know where that data is coming from. Anyway, I could go off on a rant on this as well for a while, but let's get to the next topic, which is the concept of applying natural therapies to either stop or reverse your hair loss. And so, Rob, what's your perspective? Are natural therapies worth trying?
I think in many contexts, the answer is yes. So if an individual is dealing with rapid onset androgenic alopecia, and they are losing hair by the months, and it is rapidly accelerating, and they're in deep water. In those positions, I would say don't prioritize a natural intervention. In those cases, you want to give yourself the best possible degree of success. The clinical evidence on certain FDA-approved drugs is very strong. The side effect profiles are overblown online, and given the rate of progression for your specific hair loss type, it's worth starting with this, seeing if you respond well, and then moving on accordingly. So in those cases, I think that you have to be really careful to recommend or not recommend androgenic alopecia-based natural intervention therapies. Having said that, that's not all types of androgenic alopecia. Clinical data suggests that for the average person, androgenic alopecia, it progresses by about 5% per year. So hair counts decline by about 5% per year, and miniaturization and hair volume also follow suit. And in these cases, if you're generally trending downward for a long period of time, but you're not noticing these rapid accelerations of pattern hair loss, then you're in a position to have a little bit of more leeway to experiment. And in those cases, as long as you're aware that natural interventions don't have the same quality of support and they don't rank as high on the hierarchy of evidence, it's okay, in my opinion, to try them. But the important thing is you have to set results horizons. So any type of treatment that we are trying has what's known as a results horizon. At its outset, it's based on the clinical data, the minimum amount of time that you need to be trying something to see if it's working, and then the maximum amount of time whereby if you're not seeing results, new results become unlikely. So with microneedling, that window is 3 to 8 months. With standardized scalp massages, it's 8 to 12 months. With things like saw palmetto supplements, it's 6 to 8 months. Those are the types of windows that you want to abide by so that you can efficiently navigate from treatment to treatment to treatment, or layer on treatments by abiding by those results horizon windows. But I do think that there is a place for natural interventions. And I think that a lot of hair loss forms tend to get really campy versus conventional versus natural. Those experiences are rooted in their own self-experience. And so based on the clinical data, there are interventions that work on a natural perspective. Are they as strong as the FDA-approved approach? Of course not. But it doesn't mean that we should just throw the baby out with the bathwater. A lot of these things do work. And in fact, I generally work with people who have an aversion to drugs, mainly not as such that it's because of their exposure to misinformation, but because they've tried them and maybe experienced side effects, or because they just don't fit with their worldview.
Fantastic. And I can attest to this myself. I've done both. I've done FDA-approved drugs for over a decade, and I think they made a big difference in how fast I was losing hair. But last few years, I've gotten off that as I've researched hair loss therapies that are more natural. I do want to live more holistic and natural approach. And so I've been using and prioritizing natural therapies. What Rob mentioned is microneedling. That's very effective. And also just, using hair massages, which Rob is an expert in. And so helping, my body heal by itself has been the path that I've chosen recently. But again, if you're, like you said, especially in younger men, which sometimes the hair loss is so rapid that it's definitely worthwhile going after some of those treatments. Okay, rapid fire questions. We are coming up on time, Rob. So as fast as you can go. We touched on this, but anything outside of what you said earlier, is there any impact, or what impact does aging have on the hair follicle regeneration, stem cells, and the hair bulge or whatnot? Is there, I think you've said that we can have the same hairline till we die at any age, but has research shown any impact that's aging related, not hair loss related?
There's this thing called senescence alopecia. It's called age-related miniaturization. It was believed to just be exclusively due to aging. But David Whiting, really prolific histological hair loss researcher, did a great study demonstrating that this process is likely androgen driven, meaning that the miniaturization we see isn't due to aging, it's due to the effects of androgens on our scalp hair. So in that regard, we also know that there are those case reports demonstrating 78-year-old bald men, complete or near complete stem cell depletion, and yet with the right signaling across tissues, the regrowth of a full head of hair.
Fantastic. Okay. Now we're going to talk about hair thickening or hair loss shampoos. And there's tons of marketers making tons of claims, right? What evidence do we have that anti-hair loss shampoos or hair thickening shampoos are helping hair health, are helping hair strand at the follicular level, or is it just masking a weak hair and coating proteins on top of it to make it appear thicker, but a few days later, you're back to square one?
A lot of these shampoos are just thickeners. So they will coat your hair with an artificial version of what's known as sebum, which is produced by the sebaceous gland. So they wash that away and put their own thickener on the strand. Eventually, that's going to wear off, and it's just a masking agent. Now, there are shampoos like 2% ketoconazole shampoo that, when used for 5 minutes with each session, 2 to 4 times weekly, can improve hair counts and potentially hair diameters as well. So it's not to say that all shampoos are to not be therapeutic. It's just that the ones that you usually advertise don't work the way that they say they work.
Correct. And I've certainly used 2% ketoconazole myself a few years ago, and it worked great. Rob, next question. How common are thyroid deficiencies in women and men, especially over the age of 30?
Studies out of Europe have suggested a prevalence of thyroid disorders up to 10%. So that's hypothyroidism and hyperthyroidism. Now, I think that that's pretty suggestive that these things are more common. I think that there's also subclinical cases. I don't know what your experience has been with this, but with a lot of people that I've worked with, the individuals are told that they have the onset of an autoimmune thyroid disorder, but until they can meet the diagnostic criteria over a certain number of autoantibodies, then they can't be treated for it. So they basically have to just wait until their thyroid destroys itself to begin to receive treatment. I tend to believe that those numbers are a little bit higher than 10%. I'm also open to revising my opinion with new data.
Okay. We already touched on PRP, stem cells, and exosomes, and how microneedling might be as effective or in some cases even superior to some of those treatments. So we'll skip this question. The next one was, if you had to pick a topical versus a supplement as a natural therapy, which one did you pick first?
It depends on the ingredients. So in my opinion, a supplement is going to have better tissue diffusion, provided that whatever you ingest in that supplement remains the same molecules and substances when they're reaching the actual tissues. When things get digested and converted in the liver, they can become byproducts of their original product and then get dispersed as different things that don't have the same effects as intended in vitro studies. We haven't seen that to be the case with things like saw palmetto. And I think that better tissue dispersion can be achieved supplement-wise versus topical-wise. Nonetheless, there are topical versions of finasteride, saw palmetto, all these other things that also have an effect. I think that with certain drugs like minoxidil, one of the step processes for its activation is this enzyme called sulfotransferase. If you lack that in the scalp skin, taking the oral medication can be significantly more impactful because there's a ton of sulfotransferase in the liver. All of it can get activated, and then you can really see a pronounced effect in the scalp. So it's context specific, but in most cases, my opinion is a supplement covers you better because then you also get full dispersion across all follicles and not just where you apply it.
Mm-hmm. Great. And I've tried minoxidil in both its forms, and the topical one didn't work for me so well, but the oral form had some good effects.
Oh, wow.
Yeah. Okay. Awesome. Rob, we're way beyond time, but please tell us where listeners can find you and how you can help them in case they need to get a hold of you.
You can find our research at perfecthairhealth.com. We publish all of our papers open access. We've got a big one coming out about microneedling and the use of hair loss disorders. Should be available in 2 to 3 weeks. And you can contact me personally through that site or join our membership community for more one-on-one support.
Fantastic, Rob. Thank you so much for coming on the Anti-Aging Hacks Show.
Yeah, thank you.